Odds are, when it comes to gender and human sexuality, you've probably heard the argument that, you know what, science is very clear nowadays that sex exists on a spectrum. We've got evidence of people that are intersex. We've got people who have Turner syndrome. We have complete androgen insensitivity syndrome. We've got women who have Y chromosomes. And so this archaic notion that sex is binary is just simply not supported by the science. And so people need to catch up. I mean, I've got a quote here from a woman who's the director of mental health at the Child and Adolescent Gender Center at Benioff Children's Hospital for the University of California, San Francisco. And here's what she had to say. I mean, she's an expert. She said about gender fluid children that they refuse to pin themselves down as either male or female. Maybe they are a boy-girl or a gender hybrid or gender ambidextrous, moving freely between genders, living somewhere in between, or creating their own mosaic of gender identity and expression. And so if this is your child, then how are you going to love them? Are you going to give them the gender affirming transition therapy that they need? Are you going to allow them to have puberty blockers so that they don't have to go through this alienation of feeling that they're not at home in their own bodies? Because, hey, give them the puberty blockers. If it doesn't work out, then, they can just go on, take off those puberty blockers later in life, totally reversible. And if you're not willing to affirm the gender identity and expression of your child, then, your kid's more likely to commit suicide. So if you've got a boy who perhaps identifies as female, then what do you want? You essentially want an alive daughter or a dead son. What are you going to do? This is the message given to parents that, look, you either affirm this child or you're endangering their very existence, their life. You're going to increase their odds of suicide. You're ignoring science and the best mental health standard of care. What is the answer to all of this? Well, today we've got a fantastic show lined up with a medical expert who's going to walk us through these common questions and objections. But before we do, I want to make sure to thank our sponsors here at Lust is Boring. We've got two wonderful Advent programs that are underway right now. First is with Exodus 90. Now, you may have done Exodus 90 before. I've done it before. It's fantastic. Pretty tough, ascetical 90 days of prayer and discipline and fasting. Well, they've lightened it up a little bit this Advent. And so they've got a fantastic program, Exodus 90 Advent, that you can hop in even if you've missed the first week. It's not too late. And you're going to get daily meditations, scriptural readings, plus reflections that you can read so that this Advent is really intentional, that you're going to get the most out of it. Just go to exodus90.com/Jason, sign up for this, join it with me, and it's going to be a fruitful Advent. Also, we've got the great team at Hallow. Hallow.com, as you know, is the #1 Catholic prayer app. 80,000 people have signed up for their Advent program called #Pray25. These are audio-guided meditations and prayers to guide you through the 25 days of Advent. Sign up for this. You're not going to want to miss it. Just go to hallow.com/lustisboring, and you can sign up and give this thing a try. Let's make this Advent truly intentional so that when Christmas comes, you're not going to feel like, I feel like I could have done a little bit more. I know sometimes when I have Easter and it rolls around, you get that kind of Lent regret feeling of like, I think I was a little lazy this Lent. Maybe I'm just not getting as much out of it. Let's be intentional. We only got 3.5 weeks before Christmas is here. Let's be intentional. Sign up for the hallow.com and Exodus 90 Advent programs, and it's going to be a very fruitful Advent for you. Now, our guest today, Dr. Paul Hurz. He's an academic pediatric endocrinologist, is a hormone specialist, and tenured physician scientist with faculty appointments in both pediatrics and cellular biology and physiology. Dr. Ruse has over 20 years of clinical experience in caring for children with disorders of sexual development. He's received certification in healthcare ethics from the National Catholic Bioethics Center and is a regular contributor to his university's course on research ethics for graduate students. He has authored more than 60 peer-reviewed manuscripts, scientific reviews, book chapters, together with his wife, and he has raised 5 children in St. Louis. And I came to know him because recently I was invited to proofread this new manuscript coming out called Sexual Identity. And as I read through this, I thought, man, we got to have some of these experts on the show because it's not enough to approach this difficult issue from a theological or a spiritual perspective. We need to have solid science. And the science is behind the church on this 100%. Oftentimes, Catholics are led to believe that we're out of touch with the research, but here is one bulletproof case where the scientific data supports not only the Catholic Church's theological position, but also the pastoral position that flows from those truths of what it means to be male and female and the image and likeness of God. So Dr. Ruse, I want to first thank you for taking the time to come with us on the program today.
Well, it's definitely my pleasure to be here with you.
Well, what had gotten you interested in this subject matter to begin with?
Well, certainly this is an area of conversation that directly impacts those that are work in the field of endocrinology. So the task of the endocrinologist, one of the areas is working with children that have disorders of sexual development that are born with genital ambiguity. However, very recently, this whole conversation about sex versus gender has come into play for people coming to medical professionals seeking interventions that will help to align their body to their gender identity, even if that's discordant with their sexual identity. So that's how endocrinologists have become involved. And I got into this when there was consideration for beginning that type of intervention at my institution.
Now, to begin, just the question, I know the words, a lot of people feel left in the dust when it comes to these new words of gender and how quickly just the nomenclature is evolving. That, years ago, gender just referred to, that noun is neuter, that pronoun is, masculine, feminine. Help us to understand, what is the proper understanding of the term sex and gender? Can they be thought of as distinct, or what about completely divorced from one another?
Yeah, it's a very important question because many people use those terms interchangeably and often very incorrectly. When we're talking about sex, we're talking about the biological reality of the human person, specifically in relation to their role in the process of reproduction, and that's a fairly established and longstanding understanding of male and female and what the respective roles of the members of it, not only within humans but within the entire animal kingdom, and so it's not just related to how males and female humans, but in animals and in other areas. The term gender really refers to how one portrays themselves within society with masculine or feminine traits. And so that's the term has been adopted from, as you said, from grammar to convey that reality that our sexual identity is lived out within a society. And you can think about it this way, that in order for that process of reproduction to occur, there needs to be a meeting of two members of the opposite sex to come together and enter into that union. And not only in the reproductive act that we talk about from a biological standpoint, but in the rearing of the offspring of that interaction, the children that come from that. So I think it conveys a reality, but again, can we divorce the two? To say that they're distinct terms and they refer to different things does not mean that they're unrelated, because if we lose sight of that reproductive purpose, that's where the conversation has gone in many respects. People have dismissed that sex has anything to do with reproduction, or they've certainly ignored that obvious reality, which allows people then to begin using the term gender when they really mean sex. And I've seen this in many areas as well, not only in conversations in the public, even within the research world. I have many of my colleagues that will talk about the gender of their laboratory animals, and really it has no meaning in that setting. They're specifically talking about male and female members of that species and what organs are present and how they relate to each other. So I think we need to be careful in the conversation and use the words in the ways that are being put forward.
That's very helpful. Now, one of the most common objections that is presented is that, sex biologically exists along a continuum, and individuals identify as intersex. Some people have Turner syndrome, complete androgen insensitivity syndrome, and a lot of Catholics hear these medical terms and they feel immediately outgunned. And I was speaking at I think it was University of Wisconsin a couple months ago, and the students were telling me that in order to graduate, you have to spend a semester taking a gender theory class. It doesn't matter if you're going to get engineering or pediatric medicine, secondary education. You have to spend an entire semester getting indoctrinated in gender theory. And so these impressionable young college students are sitting there, and then the gender theory teacher will explain, hey, look, here's the scientific evidence. Sex exists along a continuum. Can you get really specific in terms of some of these disorders of sexual development, why they don't constitute evidence that sex is just a spectrum of different things, and that to be this rigid and binary idea, it's male and female, is just totally disproved by the scientific literature. So please feel free to get technical, walk through some of these specific disorders of sexual development, or if a kid presents with ambiguous sexual genitalia, what do you do there as a doctor? How do we know if a child is male or female where the secondary sex characteristics might not be obvious?
Well, Jason, I think it's great that we started with that, discussion about the definitions of what we mean by sex versus gender, because that's a great place to launch into a conversation about children that are born with ambiguity and the question about the statements about sex being along a continuum. Again, the only way one can make that statement is if one loses sight of the purpose, the biological purpose of male and female. And it's important to recognize that most of the individuals that present with that genital ambiguity, the first question that any parent asks when a child is born is it a boy or a girl? And there are, unfortunately, situations where the answer is I don't know, where when you look at the appearance of the external genitalia, it doesn't look in the typical form that we see for male individuals or female individuals. But most of those individuals that have these conditions really have impaired or absent fertility. So they actually do not have that ability to really participate in reproduction or without assistance. And when you say that things are along a continuum, you're implying that has nothing to do with reproduction. There really is only two forms, and we can get specific about what is the sexual anatomy that carries out that reproductive purpose. There are only two gonads, ovaries and testes, and there are only two germ cells, the eggs or the ova from the female and the sperm cells from the male that can possibly participate in that reproductive process. There's not a continuum of gonads. There's not a continuum of germ cells that can actually participate in that. So we're looking at something that has occurred to impair the normal development into either a male or a female that has led to loss of that reproductive function. So, and again, if you're not focused on what that purpose is, it's easy to see where one can get lost in that conversation. There are many different ways. We have to acknowledge that when we look in the realm of male genitalia or female genitalia, there's variations within that. The size of the organs but for carrying out the respective roles, and they're very clear. I think it's not just for physicians. I think anybody that takes a minute to think about this can understand what the role of the male sexual organs are and what they're for, and the female sexual organs and what they are for as well. So we're looking at more than just the variations in the conditions of disorders of sexual development. We're looking at where there's true ambiguity, where it's difficult to be able to discern that, and it requires, from a medical perspective, really important questions to be asked, to be able to come to an understanding about how this actually occurred, because it's going to be important, one, for predicting other medical risks that an individual might have. There are many conditions. For example, adrenal hyperplasia is one that we see very frequently. That's a condition where there is a defect actually in the adrenal glands in the production of hormones, steroid hormones, that lead to excess androgen or male-type hormone production. So if you have a female individual that has adrenal hyperplasia, they will be exposed to very high levels of these androgen hormones. And so that leads to what's called virilization. They can become more masculine appearing. But it's not just the ambiguity that's present. That defect that led to that abnormality in the genital development can be life-threatening because you can't make the hormone cortisol, which is very important to react to stress. And so, you can't also make the hormones that control body salt. So you have to recognize that very quickly and be able to address that. But then there are questions about what happened to lead to the ambiguity. so that we can assist individuals to restoring, if possible, that reproductive purpose for later in life, or being able to participate as a male or female in sexual union. So it's important to recognize what is going on in that condition, and then to be able to intervene where possible. There are some conditions where even after one does the extensive investigation, where the ambiguity persists, where we can't really know, and then we try to do the best we can. That is probably the only situation with the disorders of sexual development where it is proper to say that one is making a tentative assignment of one's sexual identity. Again, expanding those distinctions between sexual and sex and gender. People will often say one has an assigned gender or one has an assigned sex when there's no ambiguity at all, and it's really one of the most reliable diagnoses that we have as physicians to look at the appearance of the external genitalia and be able to, with reasonable certainty, and by that I would say 99.98% of the time we're correct in recognizing the sexual identity of an individual, but just by looking at the appearance of the genitalia. So I think it's really important to recognize what we're dealing with when somebody is born with this disorder of sexual development. There's so much more I could say, and how much depth you would like to get into about the various forms. Many people aren't aware of how many. It's a very rare condition, as I said, about 0.02%. So about 1 in every 5,000 individuals would fit into this category. So it's rare, but it does occur. It occurs enough that, but if you look at each individual condition, because there are so many of them, it's even more rare for each of the different causes to be able to see this. And so we shouldn't jettison what we know about the vast majority of individuals based upon a very small minority that have things that went awry in the process of sexual differentiation.
Yeah, no, it's helpful that you're mentioning that there is a legitimate use of the term sex assigned, because I think what's happening is out of these 1 out of 5,000 cases or whatever, where perhaps there's some ambiguity, now we're taking that verbiage, at least the gender theorists, and saying that applies to everybody, that you were arbitrarily assigned a sex at birth, when in reality, it's like, well, no, your ultrasound technician is acknowledging a reality that existed from the moment of conception, that they're just conforming what they're seeing to what reality is, as opposed to physicians just arbitrarily saying, you're male, you're female. And they've taken that and just say, well, everybody's just arbitrarily assigned sex at birth, but your gender, that's something you discover and you declare. And so the kids get all confused of like, well, maybe some doctor just misidentified me when I was a kid by just looking at these superficial sex characteristics, when in reality, they missed the whole truth of who I was. And so I think it's really helpful to point out that there is a legitimate use of that phrase, assigning a sex, when there's ambiguity, but it's not something where you can use a blanket term for every single child that's created, especially when the sex is obvious. Now, when the sex is perhaps questionable, I've heard that women can actually have Y chromosomes, that it used to be like, well, it's either XX or it's XY, plain and simple as that, but it's not always that clear. Can you explain how women could have a Y chromosome but still be biologically female?
Yes, I think it's very important, to understand. So when and I think you said this earlier and very correctly, that sex is determined at the moment of conception. So that when you have the union of the sperm and the egg, all of the genetic information that is necessary to allow the developing child to differentiate into either a male or a female is present at that point in time. But it's a process, so that at the time of fertilization, when you have the early developing embryo, there's what's known as bipotentiality, so that there is a necessity for active signaling to occur to be able to allow the body to develop into either the male or female forms. In fact, the default pathway without external signals is to have a female appearance, so that there needs to be active signals to cause the development of the early gonadal structure to become a testis, and then to begin to make testosterone, and that testosterone that's being made to lead to the virilization or the male appearance of the genitalia. That process takes many weeks, and usually it's in the first trimester of pregnancy where that sexual differentiation is going on. There are active signals within the developing testis that lead to the regression of the precursors to the female forms, so that there's an active signal to cause regression of the development of the uterus and the fallopian tubes. And that testosterone that is made and the signals from the testis will then stabilize the male structures that lead to not only the gonads themselves, but all of the architecture that allows the sperm to be delivered with the seminiferous vesicles and other structures. So that process, and we know that when you can think about this in a very real way, when somebody is expecting and they want to know the sex of their child, you really have to wait until 3 or 4 months into pregnancy, to be able to determine that. But by that point in time, most of that differentiation has occurred. So you can actually see the developed male penis, or you can see the absence of that in the structures that are female. Now with three-dimensional ultrasound, you can even get into the first trimester and even earlier be able to make some of these determinations. But prior to that time, if one did an ultrasound, you wouldn't have that ability to do that. So the question about how you can have a female with a Y chromosome, it relates to how that differentiation process occurs. So you can think about it this way, that the genetic information that's present on the sex chromosomes, and again, for 99.898% of the time or even more, that we look at XX being female and XY being male. The important piece of genetic information is present on that Y chromosome, so that if you have, it's called the SRY, or the sex determining region of that Y chromosome, that's what actually sets the programming in place to allow that differentiation to occur. There are situations where one loses that genetic information, that SRY instruction that's on the Y chromosome. And as I said earlier, the default pathway is to form into a female. So if you don't have those active signals because you've lost that small stretch of DNA that leads to the male form to develop, you will go on to have that female appearance. So that's how that actually works. And you can actually have the opposite occur as well. So you can have the translocation or movement of a Y chromosome onto an X chromosome, and you can have individuals that have two X chromosomes plus this special piece of DNA that will develop with male appearance as well. So it just helps to illustrate that it's not the chromosomes themselves alone that determine sex. It is the genetic information that's present on those chromosomes. And it's not just the information that's present. It's like if you have a book, and if you never read the book, you're never going to know what's inside of it. So that if you have defects in the ability to read that genetic information, or to have the signals that actually direct that differentiation process to occur, then you will have individuals that have that either ambiguity or what appears to be a sex reversal.
Now, my wife and I have been blessed with 8 kids. We were surprised with the birth of the first one, whether it's a boy or girl, but the rest of them, my wife wanted to nest in advance and find out, okay, I need to know, long in advance if it's a boy or girl. We got to get the nursery ready. Imagine if that day comes for the baby to be born and it's not clear if the baby's a boy or a girl. It's obviously probably incredibly distressing on the parents. What do the physicians do at that point with, like, okay, we're not clear, but here are the steps that we're going to go through to get greater clarity if your child is a male or a female? Does surgery ever play a role in that, or does that take place later down the road? And what do the doctors do with the family, helping them through this difficult time?
Yeah, it is correct that it is a very distressing situation when that does occur, when the parents will ask, is it a boy or girl? And the answer is, I don't know. I think most parents, if you explain what we just discussed as far as the developmental process, it makes it easier to understand how this could even occur, that you could have that ambiguity occur. And so beginning with a discussion about how that differentiation process occurs and why there are a number of different things things that can go wrong can help. Now, the physician, as I said earlier, really there's a need as best as possible to understand what went wrong to lead to that ambiguity for some of the immediate needs that are present. So the studies that are generally ordered, we will order the sex chromosomes. We'll look for X and Y chromosomes, and we can do that fairly rapidly. We can know in a short period of time whether there's an X and Y chromosome. We can even probe for that special piece of genetic information called SRY with a special study, so we can know whether that's present there or not. One of the other studies that we do is to do imaging studies. So we'll do an ultrasound to look for the presence or absence of a uterus. Many times, if we can't feel the gonads in the area of the genitalia, that we can do the ultrasound to look to see where they're located or whether they're even present. Sometimes we can't find them at all. The testes actually, when they first develop within the abdomen, and it's actually during the developmental process, they make their way down into the scrotum. And so many times, the gonads can get caught somewhere in that process. We'll also measure hormone levels, and many of the conditions that we're talking about are due to abnormalities in hormone production or hormone action. And that could either be from the sex hormones that are being made from the gonads, or, as we mentioned earlier, with adrenal hyperplasia, from hormones that are coming elsewhere from the adrenal glands. We even have situations where there are hormones being produced in the mother due to something going on within her body that actually make their way to the baby. So measuring the hormone levels adds to that evaluation early on. The next level of testing then, because of the growth in our knowledge of sexual differentiation, we have the ability to even do even more precise genetic testing, where we can look at not only that SRY sex-determining region, but we can look at the other signals that are necessary for sexual differentiation. And sometimes that can be guided by what we learned in the earlier studies. For example, we can directly sequence the gene for the androgen receptor. So that's the action of the hormones themselves that cause the action to occur. And we can detect mutations, for example, in the androgen receptor that even though we would find, for example, an infant who has very high levels of testosterone and a Y chromosome, but appears under-virilized, meaning that they don't have the normal the phallic structure that would normally occur. And by doing that testing, we can get some insight as to what is going on there. And then, to be able to understand whether that's a partial defect that might be overcome by treating the child with higher doses of the androgen, the male hormone, or whether it's complete androgen insensitivity. Usually those infants are actually born without ambiguity. They're born with normal female appearance. Not all of the conditions that we're talking about even present within the newborn period. There are some that don't present until later in life. Androgen insensitivity in the complete form is one of those examples. That may not present until the child doesn't normally go through have menstruation at a time that we would expect it to occur. They can be born with a female appearing body, but then not have that normal process of having the first period. And then it's only at that point in time that one discovers that one has a Y chromosome, and then to be able to do the studies to be able to determine why that is. So the question about how we intervene is dependent upon what we find. So that if we find a condition that is life-threatening, we can't wait. We need to treat that either with hormones. If we find a condition that not only has a problem with the appearance of the genitalia, but it may impair, for example, urine flow, so that you can't have normal ability to urinate. That's a very urgent condition. If there's some conditions that may predispose the child to infection, it's another situation. Sometimes if it's not immediate, it still may be necessary to do surgery earlier in life. Sometimes the gonad that develops is at higher risk of developing cancer because it's not formed properly, and a testis that remains within the abdomen that is not fully formed, for example, is one situation where that may occur. But once you've set aside those issues that are life-threatening, that are urgent, or that can create health risks earlier in life, the general recommendation now is to defer any surgery to change the appearance of the genitalia until later in life. And that's due to a increased understanding of our inability to know what the outcome is going to be. Again, when you're trying to figure out what went on and how the affected child is going to be able to function in as a male or female, and whether they're going to be fertile or infertile. There's lots of decisions that have to be made, and since the child themselves can help within that. It's very interesting when we're having this conversation, as you began with, about gender dysphoria and people that have a sex discordant gender identity. There's so much that we could say about that. There's a rush to be able to do surgeries on these individuals, whereas in this area of disorders of sexual development, there's the patients themselves are saying, wait, don't rush to do surgery. It's probably better not to do surgery, and to hold off on that. So it's really a different response that's being made. I should also add, in case the question has come up in some of your listeners' minds, the vast majority of individuals that have the sex discordant gender identity have normally formed and functioning genitalia and sexual organs, at least prior to the medical intervention. So again, we're doing a lot of talking about rare conditions that are real and they're important, but it really is I would say, an injustice to these individuals to be able to lump together this other condition that we're seeing with growing frequency of people that have gender identity issues.
Yeah, I think that's an extremely important point, that disorders of sexual development are distinct from gender dysphoria. The vast majority of people who experience gender dysphoria do not have anatomical ambiguities, disorders of sexual development, and many people who do have disorders of sexual development do not experience gender dysphoria, that these are completely distinct issues. And I would even wager that individuals who do experience disorders of sexual development grow rather resentful when they're being used by gender theory proponents as evidence that gender is a spectrum. So you are proof that there's a third gender, fourth gender, fifth gender. I imagine they would not take well to that. Now, with gender dysphoria, whereas I imagine disorders of sexual development are kind of set. They're not going through the roof based upon what's latest trends on YouTube. Whereas when it comes to gender dysphoria, we're seeing incidences of this just blowing through the roof of adolescents who question their gender identity. Where do you think this rapid increase is of this, just rapid onset of gender identity questions on adolescents? Where is that coming from? And what, in your experience, are some of perhaps the causes of gender dysphoria among young people?
Yeah, maybe it would be helpful just we talked a little bit about how frequent one sees disorders of sexual development. And so we can begin with the actual numbers about what we know about the number of individuals that have this sex discordant gender identity apart from disorders of sexual development. And it's very interesting. If we look back, a little over a decade ago, when the reported statistics were provided by studies in a very different population, but there's the psychiatrists have a special manual called the Diagnostic and Statistical Manual, the DSM, that has gone through many different iterations, as far as its development, and they're currently on the 5th version of this document. In that manual, they reported the incidence of sex discordant gender identity as being very, very rare. We're talking 1 in 20 to 1 in 30,000 individuals, so incredibly rare. There's much that we could say about how we define that condition. It used to be labeled a gender identity disorder, recognizing that it was something that was not what should be. It changed actually in that latest edition to the focus on the gender dysphoria, the ill feelings that one has, really not with a scientific conclusion, but just an assertion from an ideological standpoint that this discordance between your gender identity and your sex is not a disorder at all. It's part of normal variation. It gets into this conversation about being along a continuum. But from that, not that long ago, that we recognized this to be a very rare condition, there are many people that, in surveys that have been put forward to look at this condition, and up to a half to even as many as 1 to 2% of the population will at least question their gender identity. And we're seeing an explosion of people that are coming forward to medical centers to be able to have some of these gender-affirming medical interventions. And now, there's many problems with the way that those studies are being done and how the questions are being asked. We don't fully understand all of the answers about why this is occurring. There are what we call hypotheses. That this is what we do in science: is we ask questions about what might be going on, and we develop a tentative answer, and then we look for evidence to support or refute that. Many of the people that are involved in this push for medical interventions make the claim that the incidence of this condition always was that high, but everybody was just sitting in the corners and didn't know where to go, and now they're coming forward for treatment. And you could say that's one hypothesis. There's many questions about whether that's valid or not. For example, the largest growth in this condition is within females, biological females identifying as males. It previously had been predominantly biological males that would have a female gender identity, and that whole incidence has shifted. And there's another change that has occurred as well. Previously, many of the people that were presenting with this condition presented very early on in life, making claims about what their identity. And now we're seeing the females that are coming forward with a male understanding of who they are, presenting in adolescence when they had no prior evidence at all of having sex discordant gender identity earlier in childhood. And so that's really hard. You have to really work hard to make the, test that hypothesis about them always existing as far as going on. At the same time, we're seeing an explosion of even, there's a lot of questions that haven't been answered, but even to ask the question whether social media and much of what's going on in the context of teens relating with each other might be contributing to this, meaning that an alternative hypothesis is that you have adolescent females that are encountering developmental difficulties that are now attributing this to sex gender identity discordance, when previously they were able to seek answers elsewhere and get help in addressing the underlying issues. And there's a whole host of scientific studies that actually led credence to that hypothesis. And this gets into other diagnoses that occur at the same time, and questions about depression and anxiety and eating disorders and self-image issues. It's often argued that all of that what we call comorbidity, those other psychological difficulties, is the result of the gender discordance, rather than asking the question maybe that the underlying issues then led one to identify with a sex discordant gender identity. I would say, based on the evidence we have, there probably are some genetic influences, so that we see this in other conditions as well. So if you look at alcoholism or compulsive, gambling, we know that there are genetic influences. It doesn't determine who one is, and it doesn't guarantee that there's going to be one outcome. Probably the best evidence for a genetic association or contribution is the large co-occurrence of autism with individuals that have sex discordant gender identity. It's much higher than you would expect based on that information. But if you look at the other contributing factors, if this is maybe a contributor, and it may be that the genetic influence there's never been a transgender gene identified. It does not exist, as with people looking very hard for that. Perhaps the genetic influence has to do with resiliency, or how one responds to various stresses, and so that two individuals with the same stress may respond very differently based upon some genetic tendencies. And then the environmental influences. So we mentioned a little bit about social media and what we're talking about in the larger context of ideology in culture. There are good studies that actually really lead credence to that hypothesis as far as environmental being the major contributor. For example, if you look at identical twins, that if you have one individual that has a sex discordant gender identity, if it was genetically determined, one could say that the identical twin who has the same genetics, you could even say had the same in uterine environment, there would be 100% concordance, meaning that if one person had it, the other person would have it as well. The incidence is actually higher than if you have non-identical twins. So that again gets at some of the genetic risk. But actually, the majority really there's discordance. So it tells you that, meaning that if one has it, the other one does not. So I think that there's much we don't know. I think that if we're going to answer that question in as best we can, we should say we don't know. Mm-hmm. And we have theories about what might be going on, and we have ways that we can conduct scientific studies to try to figure out what's going on. But it's going to be very important. It's not just an academic question, because if we understand causes, it's going to do a lot as we propose potential treatments. The goal that everyone has when you encounter people that have these struggles is to alleviate their suffering. You mentioned this earlier, that the claims about suicide. Suicide's not we want to avoid that. Our best chance to be able to avoid that outcome is to understand what's going on and to propose interventions that are truly going to be helpful. And if you're kind of going down the wrong track and you're operating under a principle that's not true, the outcome is very likely not to be a very good one. And we don't have the evidence yet in children that are being affirmed in their gender identity at this point in time, followed long term. But we do have data that's available in adults. And it's very important to recognize that this question of suicide does not go away when you affirm somebody's gender identity with these medical interventions. The largest studies that have been done show an alarmingly high rate of depression and suicide after one goes through these interventions. And we're starting to see that in children as well. And you can even say that each individual person that is affected by this may have different causes. Or at least influences, so that you can't put them all into one basket and say that everyone has this, the same reason why they're experiencing this. So that if you have different individuals that have different contributors to this sex discordant gender identity, being able to understand better what's going on and tailor your treatment to what is going on, which even involves, exploring some of the psychological underpinnings of what we're talking about. It's critically important to do that. That we can search all we want, for the transgender gene, or to make assertions about the brain, being structured in one way or the other. But I think we have to, be humble about what we do know and what we don't know, and then really stay grounded in what we, the basic, tenets of what we're talking about as far as human sexuality. When one says that one's gender identity determines one's sex, and there are people that say this, they're saying that biology shouldn't have any role, and that whatever one thinks is who one is. That's not a scientific statement. That is not a evidence-based assertion. It's an ideology, and we have all of science to say that there's many problems with making that assertion.
Yeah, I would imagine. It's a bit the tail wagging the dog, where it's almost as if an adolescent girl were to come in and say, I'm obese, I need liposuction, and the doctor looks at her and she's an anorexic 85-year-old girl, but it's like, well, if she thinks she's this, and then despite of any evidence to the contrary, we have to go along with her feelings instead of with data. So let's give her liposuction. Let's put her on diet pills and things like that. It'd be malpractice. But because it's all of a sudden involving human sexuality, then, physicians in many senses, I imagine, are almost muzzled of just like, well, if you can't go along with what this kid wants, and especially the parents, well, you're endangering the health of your kids. So let's get them started on their social transitioning. And then after that, the next step would be puberty blockers. So you've got some 9-year-old girl who wants to present as a boy and identifies as that, and she wants to go on puberty blockers. Now, obviously, these are drugs that have been legitimately used for many years when kids experience precocious puberty, and they kind of want to put the brakes on that for a little bit until developmentally the right time. So they've been used for that purpose, but now doctors are using these things off label, and people are saying, well, if you just decide it's not for you, then you can reverse it, and then things will take the normal course. Is that really the case, or are we using these kids in a sense experimentally when it comes to these puberty blockers? What are they? How do they work, and what are the risks that we're looking at here?
Yeah, I think that's a really important, question, because there's so much that is said, and it's said repeatedly, as we've established that it's safe, that it's fully reversible, that it gives the individual more time to explore their gender identity, and that it's not going to have any long-term, consequences. The arguments are made. Well, let's go through each of those assertions. You already mentioned, that to say it's safe when it's not been investigated with the rigor that we normally have for other conditions, is really an injustice as well, because we haven't done the controlled trials to look at effects. We already know that there are risks biologically of suppressing puberty. We know this from conditions in which puberty is abnormally delayed or becomes disrupted because of disease. In other areas, one area is bone density, so that during your teenage years, it's very important to have those sex steroids available to get maximal bone density so you don't have osteoporosis later in life. That's just one example. So we haven't really established the safety from that standpoint. There are many questions about the roles of sex hormones in normal brain maturation. The adolescent brain is not fully developed until the early 20s, and there's many studies that have been done over many decades in understanding the adolescent and how they're developing and the role of those hormones. And so when you interrupt that, you think of it this way, that it's a temporally dependent process, meaning it's time dependent. We talk about adolescence and puberty as being the same thing, but they're really two components of development for a child. Puberty relates to the biological process of going from the childlike body to being reproductively competent, to be able to participate in that reproductive process. That's what we mean by puberty. Adolescence is all of the psychological and developmental aspects related to that occurs at the same time. And if you take puberty and change, you can never turn back the clock. You can say that it's fully reversible. And then there's very, very serious concerns that this is not just a pause button. Showed that the vast majority of children that experienced sex disorder in childhood would then realign their gender identity with their sex by the time they completed puberty. About 85.
Yeah, I can imagine, if you were an adolescent boy experiencing gender dysphoria and you were allowed to kind of wait and see, and your body went through puberty and you were able to experience the natural masculinizing effects of puberty, you could perhaps through that process begin to feel more at home in the man's body because, hey, your body's respond, as it should be. Whereas when the pause button is hit, you're almost led to believe, okay, well, hey, I feel at home in a less masculine body. And then, like you said, they're progressing to the next stage, which is these cross-sex hormone treatments. What happens when you put a boy on estrogen? What happens when you begin to fill these women's bloodstreams with testosterone? What are the side effects that they're not often told about?
Some well-established risks of giving estrogen to biological males is to increase their risk of stroke. So it affects the clotting ability, and very, very serious, about a five-fold increase in having stroke. Giving testosterone to a female will increase your red blood cell count, and it's been established from very long-standing studies how that relates to risk of heart attacks and death later in life. And these are very, very serious consequences. Many of them we don't fully understand, but there are some that are already recognized. And probably the most concerning is we getting back to this biological purpose of sex. Is that it's expected that these interventions are going to either make somebody infertile or impair fertility, or make them irreversibly sterile. And by doing this in children, there's some great studies out there that the medical establishment that's providing these hormones is counseling patients before they put them on these hormones, the likelihood that they will have fertility issues. And there's a whole industry that's developed to actually counteract the infertility that's the direct result of the intervention that the doctors did. So, it's very well understood. And if you take somebody on puberty blockers and put them on cross-sex hormones before the gonads have fully matured, it's expected that it's going to be lifelong sterility. And if you ask children, that they're offered these interventions to help preserve fertility, but less than 5% will actually even consider that because they're at a point of their life where this is not something they're thinking about. I mean, when you're 12 years old and somebody asks you what the effect is going to be on future children, you're just thinking about what you're going to do next weekend, not necessarily these consequences. When you ask not the same individuals, but the individuals that have gone through these hormone treatments in adulthood, over half of them regret that they lost fertility because of this. So there's a big disconnect there, and there are many questions that we don't have the answers to. We're going forward. You mentioned, the thinking about this as an experimental intervention, and I think that is proper to think of it that way. The medical establishment that is putting this forward seems to imply that they have the answers, that they know what's going on. And I think that it's becoming increasingly clear that they really do not know the long-term consequences in what they're doing. And as the evidence builds, we're recognizing that that there's lots of harm. Now, the argument is always, getting back to this question of suicide, that even if you accept that these medical risks occur, that if that's necessary to prevent an individual from committing suicide, then it's justified. That's the argument that's made. But when you look at the data as to whether suicide has actually changed, the evidence is not there. Despite what people are claiming, that the people that have gone through these interventions continue to have increased risk of suicide. And again, it's often argued that that's because of social stress. But there are many other alternative hypotheses that are probably more firmly grounded, that perhaps the reason why this is continuing is because you've not understood and addressed the underlying issue that's going on. And we're already starting to see this in other areas of the world. The United States is still behind Europe in recognizing this. As far as more caution moving forward, you may have heard of the case of the individual in the United Kingdom, Kiara Bell, who went through these affirming procedures as a teenager, only to find out in her early 20s that wasn't the problem. And is now dealing with the consequences of having had her breast removed and her fertility impaired and all of the consequences of that. That is, again, how much we're going to see that moving forward is not known yet, but there's much evidence that this is not an isolated occurrence, and we need to be very careful.
Yeah, I would predict a tsunami of senses of detransitioners that are a bit out at sea right now. But when this wave hits of people who've gone through this process of the puberty blockers, the cross-sex hormones, and then the actual mutilating surgeries of their bodies, And perhaps there's initial euphoria that might follow the surgery of like, okay, I finally feel at home in my body. But then 5, 10, 15 years later, it didn't resolve these deeper comorbidities or things going on, that these people are going to now come back in droves, as we're seeing right now, starting up YouTube channels and ministries and websites, just begging people to hit the pause button. Because, in terms of these sex change procedures, I mean, is it, from a medical perspective, is it even possible to change one's sex? And if you could kind of explain a little bit before we close, what are some of the differences between males and females beyond the reproductive structures, that you can't just surgically tweak that and voila, the person is a new sex? Could you dive into that a little bit from the medical literature?
Right. I think, and this is an objective statement. It's not, unlike the ideological assertions that are made, it is actually impossible to change one's sex. That again, it's not just in the primary or even the secondary sexual organs. Every single cell of the body is affected by one's biological sex. And one way to think about this is that there are changes that occur in the coding within our DNA that is influenced by one's sex. And much of the genetic programming relates to biologically to what the roles are of male and females, not only in reproduction but in rearing children, from that come from reproduction. For example, lean body mass and muscle strength in males. But so we already touched upon different responses to medications. Maybe a good example would be looking at a genetic condition. You can have a same genetic mutation in a male versus a female and have two different diseases. The example I like to give is there's a mutation on chromosome 15 that can lead to a condition known as Prader-Willi syndrome. The exact same mutation, depending on who it's inherited from, the mother or the father, can lead to something called Engelmann syndrome. So there's, that's a great illustration of how important the sex is in when we're looking at how one responds, and you can't change that. You can't change at the point of conception. That is what is present, and if you give hormones or even if you do surgery, what you're changing is the appearance, but you're not changing the fundamental reality of what's there, and the consequences of that are very, very important. And again, the risk of many of the hormone treatments that we're talking about, for example, giving testosterone to a biological female, will, even if you get that into a range that's typical for a male, it's far above what a female would normally see, and it's present in diseases that we know that we need to treat. The example you can give is polycystic ovarian syndrome. We have a very, very common condition that's present in females, where we already know not only the risk in fertility, but also the risk for heart disease and diabetes that go along with that. And we recognize that as a disease. And so I think it's only from an ideological standpoint that one makes the assertion that it's just the same thing. If you raise the testosterone levels to that of a male, and many times it's even higher than that, you get the testosterone levels into ranges that are normally present in androgen-secreting tumors that we know from long-standing experience really have bad outcomes if they're not treated. So, this is something that's not often discussed, or if it is discussed, it's dismissed as being not important. I think it's somewhat irresponsible, to be doing that, and for the medical profession to be contributing to that. The medical profession is charged with treating diseases, not creating them, and the argument in sex disorder and gender identity is that there is no disease that's present, and just the logical trying to understand why that is, why you're treating people with hormones that can have very serious toxic effects for something that's not a disease, is something that we need to discuss more. But I think that you can't change sex. You can change the appearance of the body to conform to that, and the consequences of that, as we've already discussed. Some of the consequences we know. Some remain unknown, and we won't know for many years, if not decades, what the effect of this is going to be.
Yeah. Well, in closing, for our listeners who want to do more homework on this subject, whether you're a person who experiences gender dysphoria, perhaps your child does, or you're maybe in a college classroom and you're looking for some information to share that might be at odds with what the teacher's presenting. We had mentioned before the show, we were talking of 3 resources. If you could just explain a little bit about Courage, about Person and Identity, and then the Society for Evidence-Based Gender Medicine. What can people find through those ministries?
Yeah, I would say that the single resource that I think has the most comprehensive information specifically dealing with sexual identity issues, personandidentity.com it has both. It's presented in a way that it's very accessible to wherever you're coming into the conversation, whether you're a child, whether you're a parent, whether you're looking for scientific information, whether you're looking for practical suggestions about, how to talk to your friend about this, how to talk to your parents about this, how to talk to your medical provider. So I think it's a very good resource. For those that want to dig deeper into many of the things that I've said, so everything that I've tried to share with you here is based upon what we know and do not know from the scientific world. The Society for Evidence-Based Gender Medicine, or SEGM, is an organization. It's geared toward medical professionals and those that are delving into the nitty-gritty about this. But I think it actually will provide a basis, for that support of understanding if you want to dig deeper into what's going on. Courage has again been an organization that most people know about those that are struggling with same-sex attraction, but there are many people that in this whole conversation are encountering gender identity issues, and both within those that are affected by this, but also family members as well. So I think that there's some good resources that are available there, and there's also opportunities to be able to connect with other people that are struggling in the same way. There are some other resources as well, but I think those are good places to begin, because many times people that are experiencing this feel isolated. They don't know who to turn to, or at least who to turn to for reliable information. And unfortunately, much of what's being presented, even by the medical professionals that are offering these interventions, does not acknowledge much of what we talked about today. So I think it's important to know who you're talking to and whether they're aware of all of the dimensions that relate to sexual identity.
And in terms of the book that you contributed to, our Sexual Identity, any information on when that's going to be available, or how our listeners can get a hold of that book when it comes out?
So it's being published by Emmaus Road Publishing, and it should be coming out in December. It should be out before Christmas, is my understanding, and it will be available by both electronically and in print. The book itself presents things that are best presented by the people that know the areas best. And so, not just myself as a physician scientist, as an endocrinologist, but the perspective of a plastic surgeon and a psychologist, and the theology and the philosophy parts of it as well. So it was really a unique opportunity to contribute to a work that could not be done by one person alone. So that'll be available in December here in the next couple of weeks. My understanding is before Christmas, and I think the best place would be to go to Emmaus Road. It'll probably be available in many of the other venues shortly after.
Fantastic. Well, Dr. Ruse, thank you for taking the time to be with us today. I really appreciate just your generosity of time and just your courage as a physician to be able to speak out honestly on this subject, as I know we're going to be facing increased, persecution on this, especially up in Canada with the bill they're trying to pass up there right now. Some of that stuff might end up coming down here. So thank you for just being loving and bold enough to be able to speak the truth in love to these individuals, to give them the best possible standard of care without being afraid of what the world may think, being willing to do what's best for them. So God bless you. God bless your family. And thank you for coming on Lust is Boring.
Thank you. Thank you. It was my pleasure.
All
Thank
right.
you.
God bless everybody. Join us next episode. We're going to have one of the psychologists who contributed to this book look at the mental health picture of this. So we're not simply looking at the anatomy and physiology, but the mental health picture of gender dysphoria. We're going to take a deep dive with him. And then again, if you want to support us in the work that we're doing at Lust is Boring, consider contributing at patreon.com/lust or patreon.com/Jason Everett. You can support us at any amount. Help us to keep this message spread far and wide. So again, Dr. Ruse, thank you for coming on. God bless you and keep up the wonderful work.